Okay, should I sit down? Let's see, maybe I can just move that just a little bit up, out of the way. Can you get rid of some of that?
Yeah.
Okay. Are we live? Greetings, everybody. This is Elliot Lander. I'm co-founder and co-medical director of Cell Surgical Network. I'm speaking to you here from 109-degree Rancho Mirage, California. And appreciate everybody joining the webinar. We had a little technical problem. One of our cameras broke, so I'm switching right now to a laptop. I hope you can all see me well. And I have my capable assistant, Shantae, here. She's going to help me turn the pages, I think. Okay, and how do I advance this? Okay, good. All right, thank you. All right, I'm going to talk for about 45 minutes or so, and then I hope to be able to take some questions. Hold on one second. Okay, so the topic is urologic applications of stromal vascular fraction. And basically, I'm a board-certified urologist. Hold on one second. Shantae, can you do that again so I can advance? Thank you very much. And is there any way to get rid of all this over here? Stromal vascular fraction seems to be extremely effective in repairing tissue and cell signaling, regenerative medicine. I started getting involved in regenerative medicine in 2010, right around the time we started to understand that you can obtain large numbers of mesenchymal stem cells from fat. It's not really from fat. We do liposuction to access that stromal tissue that's in the and around the fat, but it also includes some very important cells that are in and around the blood vessels that supply the fat. Some of the cells potentially are pre-adipocytes, but stromal vascular fraction has a number of different types of stem cells, including hematopoietic stem cells, endothelial progenitor cells, and the mesenchymal stem cells, many of which are pericytes, or cells that surround the outside of blood vessels that feed the fat. So when you do a mini liposuction under a local anesthetic, you obtain this stem cell collection as stromal vascular fraction, in addition to a whole other array of different factors, including cytokines, macrophages, epithelial cells, white red cells. We call it the orchestra. It has a lot of different things. The stem cells are probably what's doing the heavy lifting for a lot of the work we've seen. SVF improving, for example. We use it for autoimmune conditions, for highly inflammatory conditions, and for conditions where there's a lot of cellular damage, including neurologic disease, mostly orthopedic. Orthopedic disease is probably 75% of the work we do. And as those of you who are in the network know, we all share the same methods, supplies, equipment, ideas, protocols, database, and it's basically a grassroots study, and we're all involved in pushing the work forward and collecting data and trying to understand how to best use these cells. Getting stem cells is one part of the story. How you use them might make all the difference in terms of clinical outcomes and safety. Stem cells basically work in a very simple way. They're their repair system, so the repair cells have to be able to find what's damaged, so they home in on signals. Now, if you have acute damage, which would be a loud signal, they work very well, they work fast, they go to the area and then they activate. Activation is where they turn on and do what they do, which is try to fix cells. They can do it by either becoming those cells, or sometimes they just do it by influencing those cells. They may decrease apoptosis or maybe increase synaptic growth, or there's a number of cell-mediated ways of improving and repairing tissue without actually becoming and engrafting that tissue. When we do cell surgery, which is remove a little bit of fat and use enzymatic digestion to remove the collagen matrix to free up the cells, we do it as a same-day procedure, and we are able to take the stromal vascular fraction product and put it back into the target sites, all within about a 2-hour period. the whole concept of homing, which I mentioned in the last slide, actually becomes very interesting when you start talking about chronic low-grade indolent conditions. So if you have, let's say, a radiation burn or a trauma, that's a very loud beacon, and that'll bring large numbers of stem cells rapidly to the area and help activate them. But what happens if you have a chronic low-grade smoldering problem, such as erectile dysfunction, which may occur over a 20 or 30-year period due to progressive vasculopathy? So will stem cells work on that too? Are there things we can do to improve conditions where they might respond better? This is what we've been studying now for 7 years. This is just a little picture of doing a mini liposuction. We almost always use the posterior flanks, what we call the love handle, and we make a little puncture, take out 50 cc's of fat, and that is enough to process to make anywhere from a few million to many tens of million cells. About 8 to 12% of those are the best of the best, the mesenchymal stem cells that do all the heavy lifting, so to speak. But the cell counts are very robust when you use fat. Bone marrow, particularly in older or sicker people, has maybe less than 1 in 100 times or less times the number of stem cells as fat. The nice thing about bone marrow is you don't need collagenase to make the stem cells bioavailable. They're floating freely, whereas with fat, you need a little collagenase. But collagenase is legal, and it's FDA compliant. There's a lot of interesting stories about how people came to think that collagenase wasn't legal, and it's never been the case. It's never been an issue, and we use it routinely for our procedures. Our final product is approximately 8 to 10 cc's. It has a little bloody tinge. A lot of red blood cells follow the stem cells along the path through the centrifugation, washing, and filtration process system that we do in our closed syringes at the bedside. So our final product here is being filtered through a 100-micron filter. And then this is our remedy, right, basically. We can use this and inject it into joints, or we can put it in the brain, or we can put it in the heart, or however we use it, it's really procured exactly the same way. And it's very consistent and very simple and very safe. So how do we know it's safe? Well, we've been watching carefully for 7 years now what kind of outcomes we're having. We have a very interesting collection of data from our online database. When patients have treatments with us, they respond directly to the database. The database sends them questions every 3 months on how did they do, did they have side effects, adverse events, fever, cancer, whatever. We ask them many, many questions, and the patients turn in those, they submit their results, and it goes directly into the database, and we query the database. We look for trends, we look for side effects, we look for adverse events. We question anything that looks like there may have been a problem where we may have to talk to the patient or the physician. But we have, many, maybe over 100 locations now putting data onto the database, and we have over 6,000 patients actively in the database. It's the largest regenerative database in the world that we know of. We have all our IRB studies collecting that data, and it's funneling through that database. We use the database to publish our first 1,524 patients that was published in a peer-reviewed journal in March of this year. And it's the largest series in the world of safety with IV cells. So we can put the cells directly into the bloodstream, and we're not seeing pulmonary emboli and infections and things that maybe were theoretical risks 7 or 8 years ago. Okay, so let's take this to urology. Again, I'm a board-certified urologist for almost 30 years now. Once in a while, I like to put on my urology hat. And we understand that there's a lot of urologic diseases that may respond to SVF. It's kind of interesting studying SVF over the past few years because in parallel to the work I'm doing, I hear about these really cool high-profile studies such as this one from North Carolina, where basically they're growing organs. Stem cells are used in a laboratory to grow a bladder in this case. That's a human bladder. It's possible now that the technology exists for growing some simple human organs, especially those made out of cartilage, ears and noses and tracheas and things like that. This bladder is probably one of the most advanced. The problem is some organs are really complicated, such as kidneys. And I think we're a number of years away from when we can build organs in the lab on stem cells. And I know that's the dream, and everyone talks about it, and It's fantastic. It's very exciting. However, we don't have this tomorrow. If you have a problem with your bladder, it's not very easy to get to the lab and put this in your body, obviously. So how do we do, if we can't buy the whole car, can we replace one part at a time? So could we regenerate damaged bladders, for example, by just working on a cellular level? If stem cells detect damage, cellular damage, disease, or degeneration, might they mitigate that by just repairing or attempting to repair that one cell or that group of cells? And if you did that, certainly over and over again over time, could you slow down or stop or even reverse and improve chronic degenerative diseases such as bladder dysfunction? And today, as a urologist, we're going to talk about some really interesting ones like erectile dysfunction, but really any urologic organ can be probably improved by cell therapy if under the right conditions. So why is ED out there being marketed so much, but no one can find papers on it? And the answer is there are no papers on it. There's almost no data on it whatsoever. There's a few anecdotal stories. There's a little bit of literature. I'm going to get to the boring part of the webinar where for about 5 or 6 minutes I'm just going to show you some of the data that's in the literature. So bear with me and just hang in there as we go through these. It's important to understand that the marketing is ahead of the science when it comes to erectile dysfunction. There's people all over the world offering stem cells for ED without a shred of evidence that it works. But we've now gotten to the point where I think we can do better than that. So back in 2004 was the first work done on ED with stem cell therapy, and since then there's been many, many studies in the literature. As of last year, there was 40 additional studies. I believe there's more now. Almost all of them are using rats, and we have a few that are based on human work. This particular publication came out of Korea in 2010. They treated 7 diabetic men with umbilical stem cells, and 2 out of 7 improved, but they had to use Viagra still. In 2013, bone marrow mononuclear cell concentrate was used. These are basically bone marrow-based adult stem cells in most cases. And it was a single case report, little improvement was seen. This particular doctor in France presented a paper with quote-unquote promising data in 2014 for a phase 1 trial on post-prostatectomy patients. In 2014, I presented a poster at the Western Section American Urologic Association. We showed erectile hardness grading scores and international erectile function scores improving nicely in our series. The poster was completely ignored and there was no interest in it. There's probably hundreds of millions of men in the world who suffer from ED, and you would think that there would be a little bit more keen interest in the topic of ED, especially regenerative medicine, because it's really the next horizon. Not everything will always be phosphodiesterase inhibitors, but there really is no real interest so far. Here we are the next year in 2015. This group took 6 case reports. They introduced 10 million cells. These were adipose-based cells, and about 2/3 of the patients improved, and also their diabetic factors improved. So that was kind of interesting. And another human study, January of last year, these were placental-based stem cells. I don't know much about those cells or the quality of the cells or exactly how they evaluated their cells, but they did administer them to 8 patients intracavernosally, and they noticed some peak systolic velocity increases, so that suggests that vascular flow improved. The subjective outcomes tests were not that impressive. At the end of the day, you have to ask patients, does this give you erection? And it's like, well, just because your speed of blood flow might be looking better on ultrasound, at the end of the day, the patients have to tell you whether they're getting, improved sexual function. So subjective outcomes are everything when it comes to ED. But so anyway, they had a slight, mild improvement in a few of the patients. Here's a real publication. This is patients following radical prostatectomy, and it got a little bit of attention. It was March of last year. 8 of 17 men improved. The interesting thing is that of the men who improved after prostate surgery, this is radical prostate surgery for cancer. The nerves run through the prostate and they get damaged during that surgery. The interesting thing is that almost all the improvements were in patients who were continent, which means that they did a delicate dissection of the apex and the bladder, neck, and they handled the tissue differently. So men who were able to retain, I should say, continence function, those are the ones who also achieved erectile improvement. So it's kind of interesting. It shows you the type and quality of surgery made a difference. The big problem with this study is that it's basically worthless because, excuse me one second, there's a little glitch. It says my, okay, hang on one sec. I'm just going to re-bring up my slide. Thank you. I'll tell you why this study, which is the only half decent looking one in the literature, is worthless, is that if you take, hold on one sec, let me just go back. If you take 17 men who just had prostatectomy, within 18 months, about half of them will regain their erection spontaneously. And that's the same results they got with stem cells. So I see no evidence that cell therapy did anything in these people. All right, here's another one. This one is basically a number of different patients, a number of different groups, I should say, that this is the same guy from France who had presented promising data 3 years before. But what he did see is that Doppler ultrasound results did improve for a number of these patients. It seemed to be related to dose, cell dose, so that there was 4 groups, and the patients who got the highest doses seemed to do the best. And they did actually have improvements in their intercourse and function, based on subjective outcomes tests at 6 months. And it looks like, as I said, the higher doses did better. It's only 12 patients. A significant improvement was seen overall, but we don't know exactly how many patients got better. There's a little bit of data missing from that publication. And I'll show you data today from our network that shows not just how each group of patients did, but also overall data. You can look at it either way. And then one more publication from the Ukraine earlier this year, 19 patients, quite a few of them improved. 40% were able to penetrate at 6 months when they received fetal stem cells. Okay, that's it. Human data. That's for the planet Earth for erectile dysfunction in 2017. Almost basically, there's no human data. At this time, I thought it was very important that we start to look at our data in a little more rigorous way, apply some statistical evaluation to what we are doing, and see if we can contribute to that data. Our protocol is basically to inject intracavernosal for 20 minutes. We clamp the base of the penis with a little rubber tourniquet and inject intracavernosal. A lot of our patients are receiving shock waves, about half the patients. We use the D-actor device by Storz in an off-label fashion, 500 shocks per centimeter. It's approximately 5,000 to 6,000 shocks, basically, for the average person. It takes about 7 to 8 minutes to deliver them. And then we did erectile hardness grading score and IIEF testing. That's the machine, the Storz generator and shockwave machine. And that's what the deployment handle looks like. The energy comes off about 20 millimeters distal to the tip, so it's deep tissue energy. It's not painful. You don't have to anesthetize the penis unless you're using it at higher settings. For example, Peyronie's disease has higher settings, but for ED, it's a low energy vibration. It was based on the Gruenwald work, which was really got a tremendous amount of attention out of Israel in the last few years, where they said shockwave. This is the same technology we use for kidney stones, by the way. But they said that shockwave improved more than 2/3 of the patients. They were able to achieve erections. They needed Viagra to do it, but they were able to achieve erections. And then they also determined later that they seemed to be activating endogenous stem cells and Schwann cells, which are like basically wannabe nerve cells. So histologically and efficacy-wise, it looked like they were onto something. Not a lot of groups have recapitulated this work, but it did get a lot of attention, and it's the reason I decided to use shockwave on some of my patients. So if you take our patients, basically you can look at the erectile hardness grading score at baseline and over 2 years, and we're seeing some results of improvement in hardness. We had 85 patients, and we had this is the same erectile hardness grading score. This is baseline and 6-month mean hardness grading score, and it's statistically significant. Now, 36 of those patients received shockwave, and they also improved. Not so, basically, not as statistically. The p-value wasn't as good, but it is an improvement, and it's close to significance. And here's with no shock. It looks like even a better improvement. The slope is even higher. Again, statistical analysis, it does look significant. But interestingly here, it looks like no shock. Actually, those patients maybe even did a little bit better. But let's look at it a little deeper. Let's drill a little deeper. Here's erectile function scores on 76 patients. They all seem to be going up from baseline up to 2 years. This is the overall erectile function. Again, this is a subjective outcomes test. And again, that's 76 patients. I think I said 85 before. It's 76. And this is a statistically significant improvement in function. This is with shock, and it's okay. Here's with no shock, and not quite as good. So with shock maybe helped on that parameter. Here's orgasmic dysfunction. You don't expect orgasm function to change much when you're talking about erectile function. So that didn't change much. Sexual desire, again, that's driven sometimes by testosterone and other issues and relationship issues, so no big change there. Overall satisfaction with ED. Baseline, it went up. It was significant. Look at the p-value. This is baseline at 6 months. People were satisfied overall. That means guys who got, when I say overall, that means the half who got shocked and the half who didn't get shocked. They were satisfied with the stromal vascular fraction deployment in terms of their sexual function. There's with shock, very significant. No shock, maybe not so much. So here, when you start splitting the data this way, where overall satisfaction, shock is coming in pretty good. It's looking like shock adds a lot to the story. And again, overall, this is IIEF. This is a standardized test urologists give every day to their patients. International Erectile Function Score. Overall, really nice, significant number, really low p-value, improvement over baseline. With shock, significant. No shock, not so good. So shock actually is pretty coming into, a little bit more of a favorable status. And if you look overall, and not just overall results like we talked about on that earlier trial, if you just start looking at how many people, basically around half the patients reported improvement, but the ones that did, like 2/3 of those did receive shock. So more of the improvers received shock. So bottom line is SVF does seem to work, at least in our series of 76 patients, which is 3 to 4 times the size of the largest series ever in the world. And adding shock protocols does seem to improve things. Now, shock is imperative when you're treating Peyronie's disease, because one of the things we're trying to do is break down the fibroblast aberrant plaque formation, which is an abnormal scar that occurs in the tunica albuginea, causes curvature and shortening. And the shock waves are used at a higher energy under local anesthetic to break down that plaque. These patients have severe curvature, sometimes making it difficult to perform intercourse. When we added shock, if you do a little bit of research on what shock waves do, they seem to home and activate the stem cells. Remember we said stem cells home and activate based on beacons of damage? If you're using a lot of energy, if you're applying energy, it will send out cytokine beacons that help the stem cells come in and activate. So it's a nice synergistic effect when you're combining it with stem cells. There's some data suggesting shock waves are angiogenic, so you do want to replace scar with healthy blood vessels. We had a small series of 11 or 12 of these patients that I published last year. This is plastic and reconstructive surgery, and we showed really good results in these people. We anesthetized them. We used the shockwave, much higher pressure, 3.8 to 4 bar. Once the plaque was broken down, so to speak, you could feel it soften. Every patient would feel and go, wow, that's soft now. I feel the difference. But if you didn't do anything at that point, it would just come back within the next few weeks. But if you inject SVF directly into the softened plaque, we get a huge difference in the plaque reformation. So here's a Peyronie symptom. It's like a 26-point questionnaire. Everyone uses that in urology, the Peyronie symptom bother score. They started at 8 and went down to 4.8 at 1 year. So their symptoms of Peyronie's improved. Again, with shock, 4.5 down to 3.4 on their pain score. The reason why we check pain is About 40% of people with Peyronie's have pain, so we look at pain scores when we're talking about it. Psychological effects of Peyronie's, again, beautiful drop from 11.9 to 9.8. And the overall total score, it went from 23 down to 11 at 1 month, down to, and then it went back up at 1 year to 18. A lot of people had need for repeat treatment. So when you're dealing with significant Peyronie's, you have to tell patients that one treatment may not do it. But a couple of treatments sometimes makes a huge difference. So that, I think, is going to be a winner. Peyronie's, we have published data supporting it. It works. I've seen it work myself. It works in probably 80% of people generally if you're offering them Peyronie's treatment with the shock and the SVF. For ED, it's closer to maybe 50 or 60%, but for Peyronie's, it's really hitting it out of the park. Okay. It's very important that we spend just a few minutes talking about interstitial cystitis. Anyone in the urology world knows that it's one of the most dreadful, miserable conditions that we know about. There's no therapy that really mitigates it or makes a big difference. It works much better than placebo, and it destroys the lives of millions of people in the U.S. That same nice lining that protects your stomach so you don't digest your own stomach, we also have it in the bladder. That glycan layer is deficient in these patients, and there's probably some autoimmune features to it, but their bladder is not protected. Their urine burns their bladder. It causes caustic burns, which sets up inflammation and ulcers. Pain, overstimulation of afferent pain fibers in the pelvis, chronic pain syndromes. A lot of these people are addicted to opiates and are unable to work. They get a lot of lesions in their bladder, but there's no single finding that rules this in. This is considered a diagnosis of exclusion. I've been treating it in a three-pronged approach. I try to encourage people to use a barrier restoration to try to coat their bladders in a meaningful way for a few months after the stem cell treatment. But the SVF is injected systemically to work on their immune systems and also regionally. And what does that mean regionally? Well, here's the IV infusion to work on your immune system and your systemic inflammation. It also mitigates overstimulated nerve fibers to decrease pain traveling and pain sensation. SVF seems to be very effective for pain syndromes, by the way, and anti-inflammatory effects. But regionally, I'm using it to help with the nerves in the bladder. So there's targets in the trigone, there's targets around the bladder neck and around the urethra, and those areas they're all tackled under a local anesthetic and just a pelvic exam in the office. And you can also inject into certain pelvic floor trigger points, and it really helps people with pain. So out of 86 people we treated with IC, 64 reported improvement. I have not seen that in my urology practice with any agent whatsoever. Elmeron, which is one of the only 1 or 2 FDA-approved treatments, is an oral medication. It's basically essentially the same as placebo, maybe 2% better. This is a lot more compelling. If you measure pelvic urgency frequency scores, it's a 0 to 35 score. The baseline, and 22 is pretty bad. I mean, these people are debilitated. At 6 months, we were down to 15. So we see urgency frequency. O'Leary-Sant, same thing, voiding and pain symptoms. They're going from 25 down to 16. It is not a cure. It's not a cure for, for IC, but it mitigates things. Sometimes the difference between 25 and 16 is the difference between being able to leave the house or being on opiates and not being on opiates. Here's the overall pain scores, 5.9 down to 3.8. Big change. So IC, I think, has really a lot of potential. The patients are complicated. They have a lot of other issues. They often have other medical problems, autoimmune conditions, and digestion problems, and you've got to treat them globally. The nice thing about what we're doing is that we're addressing it globally with a systemic IV infusion. Now, the bad thing about IC is it comes back. It's not a cure, and a lot of these people, a year or 2 years later, will need repeat treatments. And that's not necessarily bad. It just means that you probably worked on their immune system a lot, and then they need re-immunomodulation to happen once again. So I tell people up front, if this helps, good. But then if it does, be prepared to come back in a year or 2 years, or maybe you should just come in a year, regardless of how you feel, to kind of keep the boogeyman away, so to speak, and try to keep you okay. So what else can we do with SVF? I have a small series of patients I've used it on after prostatectomy. I've done probably 600 radical prostatectomies before in my career, and the biggest thing is what happens after the surgery. You know, are they going to heal their bladder neck nicely and be continent? How do we handle the nerves? Will they have erectile dysfunction? And I think we can do better than what's out there, because SVF actively accelerates and promotes healthy healing with mitigation of nerve damage and new blood vessel development, and healthy tissue instead of scar. A lot of the incontinence is due to scar. So I think people who've had a radical prostatectomy and many other major surgeries, but especially this one, they should come in and get SVF within a week or two after their prostate cancer surgery. And a number of my colleagues have offered this to patients in their practice, and the patients have been happy. Now, can we prove it worked? The patients say, well, I got my continence back in 6 months. Maybe they would have anyway. It's really hard to know. Until we start working with large institutions that have done series on thousands of people and have data saying, mean time to continence is 8 months and we made it 5 months or something like that, we can't say for sure. But until I see that data, I would support treating empirically. If it was me and I had a radical prostatectomy, I'll say, I don't care about the data. I want SVF after the surgery, please. Female incontinence, especially stress incontinence, type 1. I omitted type 2 and 3 because those are pelvic floor descent problems. They probably need the bladder suspended, so to speak. Intrinsic sphincter deficiency, that's urethral atrophy. These are things that should respond extremely well. We don't have a protocol yet. I'm actually kind of playing around with one now. I'm designing one where I think we can help these people. Incidentally and anecdotally, I've had probably 24 patients who came in for cell therapy that didn't have incontinence when they walked in the door. In other words, they didn't complain of it, but they had it. And then they mentioned it to me, and I treated them by injecting them around the urethra, and pretty much all of them responded. So I just talked to someone the other day. We were treating for IC. She goes, by the way, I don't leak anymore. So it does help with mild leakage. I think that has a lot of potential. As far as cancer, SVF has a lot of potential uses in cancer, mitigation of radiation and chemo damage, but particularly, right now we're working with a tumor vaccine, using autologous stem cells to deliver a tumor vaccine. We're setting up some phase 3 trials on the West Coast to treat head and neck tumors, prostate cancer, and breast cancer, triple-negative breast cancer. And the prostate cancer treatment will be focal laser ablation of prostate cancer, which is MRI directed and does not cause impotence or incontinence because it's just taking out the cancer. And some of those patients have a certain finite recurrence rate or persistence rate, and we're looking at injecting stem cells with the vaccine into the area on one cohort of patients to see if we can improve those statistics, and we strongly feel that we can. There's a keen interest in renal disease, and we're talking with some people now who are in the dialysis industry who want to try to offer that to their patients to see if we can improve some of the problems associated with renal disease and dialysis. And we don't have data on that yet, but it's an area that has my attention. So what is the future for urology? Well, ED is one of those quiet syndromes. It's not like a radiation burn or a knife wound that gives off high signals, and it may need higher numbers of cells. So, one of the options is banking cells and expanding them, and maybe that might be helpful for the ED patients, and that needs to be looked at. There's certain conditions like Peyronie's and interstitial cystitis that require repeat treatments. Banking is good for that too, because then you can just do one liposuction. Patient has their own personal line of cells, and they can use them a number of ways and over a number of years. What about healing from urologic interventions? We talked about post-radical prostatectomy. There's probably a lot of urologic procedures that would benefit from being followed up with SVF. We know that we've been doing that in the orthopedic realm. It's very common now for people to have, maybe an arthroscopy or a shoulder surgery where there's something physically done that's not related to cell therapy, maybe a bone spur shaved down or a tendon reattached or something like that, and then you follow it up with stromal vascular fraction, and they heal really fast. It's really nice to see. It's a great adjunct to traditional surgery and other medical interventions. And then the really interesting thing is, what about prevention? Okay, so people got vasculopathy and then got ED, and then when they're 70 years old. What if in their 50s they were getting infusions of stem cells every year, their own stem cells? What would that change? Well, stem cells are highly anti-inflammatory, and cardiovascular disease and vasculopathy is intimately related to systemic inflammation. Maybe we can decrease inflammation. Maybe we can improve blood vessel health and improve new blood vessels along the way without waiting until it's broken. In other words, you know, preventive maintenance, just like we do on our automobiles. I don't think that's, you know, so far off, and I think it's going to make a huge difference, and that's something we should be offering our patients. So freeze your cells. You can use them for that. It's your own DNA. You'll never have an allergic reaction to them or an infectious disease problem. We have to figure out what are dosing schemes for frozen cells. Now it's your own personal medicine, so how do you use it? And, you know, we're always working on that. Cell Surgical Network is not me and Mark. I mean, it's 300 or 400 doctors working together. Everyone's sharing ideas. It's an open forum, and everyone is constantly emailing back and forth and helping each other, telling each other what they found works and what doesn't work, and helping them to help their patients. It's the largest exchange, egalitarian exchange of information that I've seen in my career. Most of the exchange of information in my urology career has been very unilateral. The flow is downhill. You know, the textbooks and the meetings from one luminary or thought leader to a group. This is a little bit of a different model, so I'm very proud of the Cell Surgical Network model. We're all investigating together, and I think people will call me and say, I tried this. What do you think? And that's the only way to know. You know, we have to do basically investigational work and use the data from the database to validate it, to make sure that we're going in the right direction. So at this point, I think that's a pretty good overview of where we've been and where we are and where we're going for the urologic world. I was able to receive a few questions in advance, and I'll be able to answer them. If more questions come in, will I be able to hear them on this, or email? Okay. If you want to email questions in, feel free to do that. The first question is, what are you doing now for interstitial cystitis, and is the stem cell a complete cure and an IC won't come back? So I think you saw, based on the data I showed you, that we're mitigating one of the most miserable conditions in the world. But I would never tell anyone a stem cell is a cure for anything. But if we can mitigate something in a meaningful way and improve quality of life and decrease pain and document that, then we've really, I think, done someone a service. And it says, a follow-up question, does one have to heal their leaky gut first before they do stem cell? You know, I think that's really a separate issue. The leaky gut may heal to some degree from the IV cells, but I'm not claiming that. I don't know that for sure, but that's, it is something that has to be addressed, but it can be done simultaneously. Next question, it's been almost 3 years since my stem cell treatment and my pain has reverted to its original condition. Would you recommend another condition? How would you recommend? You know, basically this is one of those things where pain, if you're doing IC, the pain, this is a very common story. The pain will come back a couple years later, and then you have to do it again. So after a number of treatments, maybe it won't come back so fast. We've seen that in some of our autoimmune conditions. But I don't think people should think of stem cells as a one and done. You know, people will say, well, I went to China and had my Parkinson's treated. And I'm thinking, that's absolutely impossible, because Parkinson's is a chronic neurodegenerative disease that requires it requires a program, not a treatment. You can never do enough cellular repair with a treatment. It's like saying, I had, extreme pneumonia, life-threatening pneumonia, and I took a amoxicillin pill, 500 milligrams. I think you're going to want dosing. And as we come to understand, especially with expanded autologous cells, as we come to understand how to dose, we can make a big impact on some of these conditions. Does SVF IV therapy have any adverse effect? We've had no infections, no PEs due to the SVF, pulmonary emboli. We give penile injections and Peyronie's injections. Those are the equivalent of intravenous, because it goes into the sinusoids and the corporal tissue, which is basically, unless you have a tourniquet on, that communicates with the IV system. All of our other conditions, we just put it in IV antecubital. But IV therapy is essential. You should treat patients from a global and holistic approach, not just as an organ. Next question, which of the stem cell therapies is best for ED? Adipose, blood or bone marrow? Okay, here's a great question, because people who are vested in certain industries or technologies will tell you that theirs is the only one that works. I always laugh. It's like the martial arts schools. Everyone thinks theirs is the one that's the only one that works. Well, all these cell types potentially work. Adipose provides basically the same stem cells as umbilical or bone marrow. It's just that, you know, as long as it's autologous, there's a few slightly different markers on those cells, but they function the exact same way. So just find a technology that works. For example, Cell Surgical Network, we use adipose because it's there in abundant quantities just under the skin. It doesn't hurt. You don't have to have a bone marrow biopsy. It doesn't hurt to get it. And the cells are fresh and they have tremendous proliferative potential. If the patient's very old or sick, the bone marrow is depleted. It doesn't happen to the adipose tissue quite as much. So we find adipose, for a lot of reasons, works great, and we're very happy with it. Next question. What specific bodily components are attracted to the injection site due to the presence of SVF? Does this induce repair activity at remote sites? The answer is yes. I mean, every day I treat someone for an IC and they tell me their neck got better. And I'll say, I didn't know your neck was bad. And they'll say, yeah, I forgot to tell you. I had arthritis in my neck and it's gone now. It's, I think, one of the important things to emphasize about using the systemic therapy, the IV therapy as well. It finds its way. The cells are smart. They're smarter than we are. They know how to find the damage. I mean, we can synergize with that by doing a regional deployment, by injecting into a disc or into a bladder. I mean, I'm not saying we shouldn't use focal therapy, but we also should not discount systemic therapy because the cells are so smart. They know where to find the damage, and once they're there, they know what to do. And sometimes they function better than the engineered or differentiated cells that come from, you know, research projects and labs, because the cells respond in a smart way when you just introduce a progenitor cell to a degenerative problem. Someone asked about if we have to do repeat injections for ED. You know, ED has been one-time treatment, basically. Peyronie's has taken a few. A knee or a shoulder or a hip maybe is one time, but an autoimmune or a neurologic disease would be several deployments over years. You have to really look at the condition you're treating, and then you'll know whether it's a one-timer or it's more of a program. I have one more here that just came in. Let's see. Do you do any testing on bank cells you receive to make sure they're viable? Yeah, you know, if we bank cells, they're going to basically GMP quality labs. So there's extensive disease testing done on them and viability, and also any cell that we receive or that we create, you know, we make on a point of care, we always check viability before we inject them back into a patient. The only ones giving non-viable cells are the thousands of doctors offering amniotic stem cells and some of these little packages. You know, there's a lot of people saying, come to us for stem cell therapy, and it's actually amniotic cells. Amniotic cells are not alive. They're gamma radiated. If you look at the ingredients on the package, it says cell matrix and cytokines. So there's no live cells in there. If you tell the public you're doing stem cell therapy, maybe you're not lying, but it's a bit disingenuous because you're not really telling them you're giving them dead cells for an anti-inflammatory effect. They're popular because they're cheap. They appear to be FDA approved, so people are getting them and shooting them in. And there's no data yet on their safety or viability or, you know, long sustainability. I'm not a big fan of the concept. So I think there's nothing better than your own cells. There's nothing better than your cells from fat. There's nothing better than your own banked cells. And they have your DNA, and they're in your body for one reason only, and that's to repair you. And if you use those on yourself, it's very compelling. Okay. I just want to thank you all very, very much. If you want to email me additional questions, email me at info@stemcellrevolution.com, and I'll be happy to reach out to you. And I hope that you know, this was valuable to you and your regenerative learning curve. Thank you very much.